Welcome at the 26th episode of Botcasters. Today with James Benoit, researcher, postdoc at the University of Alberta. Welcome, James.
Hi, Doran. Thanks for having me on the podcast.
Thank you for being here. You're from Canada, so we have a bit of a time difference.
Yes,
for me, it's evening. For you, it's morning. Please introduce yourself, because I said you are a researcher, but I didn't say what.
Sure. So I am a postdoctoral fellow at the University of Alberta, and I primarily work with health technology in trying to take new tech like AI, like large language models like ChatGPT, apps, and translate them into something that people can actually use either in the clinic or at home.
And that's how we found each other, because you were mentioned and quoted in an article that was about your research. And that triggered me because, of course, we are Botcasters. We're about chatbots and conversational AI. And I have a passion for healthcare. And in our pre-discussions, we ran into this discussion or this problem. We actually agreed, but something needs to be done. And hopefully today we get a little bit further, is that if you look ahead and see what's happening, then we see consumers or patients will start using ChatGPT and similar models, put in their medical data, which they can take out of the hospital system or the doctor system, because they have to make it available to the patients. Mm-hmm. And then put it in the system and get some results. And some are good, some are not so good. And that's not the real problem. The real problem is these people will get this information, don't know what to do with it, and go to the doctor with all that information and say, hi, here I am. I have 5 differential diagnoses, and the system tells me that I should take these medicine. What do you think? And then instead of having less work, the doctor has more work. And the systems all around the world are already constipated, as we would say.
Yeah, resources are already scarce in healthcare as it is.
Exactly. So this is where we found each other. It's like, okay, if we look at this, something is going to happen. And we were both afraid or worried that doctors have no clue what's going to hit them when this sort of breaks through and all the patients are going to use it.
That's right, because the question comes up when they step into the office. The flip side of the coin is the doctor ready for this? And if they aren't ready for it, how is that going to affect that doctor-patient interaction? Exactly.
And there's another thing, and hopefully we can talk about that too, is that you see all these doctors, at least in Holland, a lot of it is protocolized. There's protocols for this, protocols for that, and maybe 90% that's correct and that fits, but the other 10% it doesn't fit. And what you see is the patient is being sort of ripped apart in pieces, and a little bit for a doctor here, a little bit for a doctor there, and we are one system. And what is missing, in my opinion, like the GPs are working or pediatricians are working, a more holistic view on care or health, where systems or different diseases or medicine interact and cause and effect. And there's a lot of studies being done on that. But a lot of doctors really don't know because they're stuck in their sort of protocolized world.
Yeah, absolutely. And I think that's an area where we're going to see either things go very well or they're going to be rough at first and then go better with models like ChatGPT.
So what's your vision? Sorry, no, go on.
Yeah, so I mean, my vision for using ChatGPT first is that it replaces a lot of the rote inputs that we need to take at a clinic. All of those patient histories, all of those questions that somebody could answer just as easily from the comfort of their home or on an iPad in the office before they get into the clinic. I see this as an enormous time saver in the future and an enormous cost saver in 2 ways, really. Number one is just cutting down the time that doctors are doing administrative work, which frees them up to actually practice the art of medicine. And number two is in how we train those doctors. So while these tools are coming online, we have an opportunity with them here to start using them to allow doctors to train using different patient perspectives. And that's where I see a big benefit of this is you're going to have less medical interactions where the doctor isn't comfortable interacting with the patient where they haven't come across a certain situation before. And we can use these big tools to train them up in these situations. And then as people come into them, manage those situations effectively in the clinic so that people have a pleasant pathway of care from start to recovery.
I shared yesterday an article with you. Maybe it's good to bring up those percentages, if you like, because I was astonished by it. And you're the scientist of the both of us. So I was interested how you view these percentages, and maybe you can either share them or mention them.
So these are percentages that came out of a Harvard preprint, I believe, in ChatGPT, out of Tive Mehrotra's lab, I believe. And what they were doing with this is they gave a set of clinical vignettes to lay people, gave a set of clinical vignettes to doctors, and gave clinical vignettes to ChatGPT, and asked each set of participants to provide differential diagnoses for these cases. And they were interested in what is the accuracy of finding the correct diagnosis in the top 3 diagnoses. So, sorry, do you have the numbers in front of you there?
I have them on my phone. You talk, I find them.
Sounds good. So the numbers here basically showed that ChatGPT performed better than lay people at diagnosis, but a little bit worse than the group of physicians. And those are interesting results.
I'll give you the numbers. Online symptom checker, 51% of the cases identified actual diagnosis. Mm-hmm. The physicians, 84% accuracy. ChatGPT, 87% of the cases included the correct diagnosis within the top 3 results. Mm-hmm. And they said one warning, again, use these with caution as the cases came from textbooks and training materials and might not reflect how patients would self-describe the symptoms. But this definitely raises the bar and invites an opportunity to push symptom trackers to the next level.
Mm-hmm. Absolutely. And this is one of the first times where we've seen essentially a base large language model being used to produce results that are approaching human accuracy. Now, there's a lot of question around and a lot of controversy around whether there's any meaning behind the words that ChatGPT uses, and a lot of concern that it's going to hallucinate answers or provide spurious results. That is something where we did a very similar test. We gave it a set of clinical vignettes, but we were only interested, because we're working with children's health, we're really only interested in the first diagnosis. Because thinking about this like a concerned parent, you don't really care if the second diagnosis is correct if you have ChatGPT giving you the information and you don't have a backup source to go to. So in order for this to be a realistic tool to use, we need to have it be right the first time very consistently. And so when we reran a lot of the original vignettes that were used in this research, we found that ChatGPT was producing results that were comparable to a previously run study with the vignettes for first pass diagnosis.
So that means ChatGPT did well.
It did very well. It did well enough that it is comparable to physicians' accuracy. But the one place it does really fall apart still is triage. So ChatGPT is good at coming up, taking a case and saying, okay, I've taken a look at this. You've mentioned that there are 5 different medications in this case that use acetaminophen. So I'm going to talk about possible acetaminophen toxicity in my diagnosis. However, it doesn't do so well when we say, okay, well, what should we do with this? Should you go to a hospital, go to a clinic, or care for this illness at home? It's very good at saying, actually, you should go to a hospital. It's very good at saying you should go to a clinic, but it falls apart almost entirely on home care. So we still see this classic problem that we've had with chatbots and with symptom checkers and these automated diagnostic systems, which is that they are too scared of telling people to manage their own illness. And scared is maybe not the right term. It's anthropomorphizing again. The bots are designed so that they are not going to cause harm. And the most reliable way of not causing harm with the disease is going to see an expert and getting them to check it out. Right? That's sort of our current best practice for when you get sick.
Is that also maybe a liability thing?
Oh, absolutely. If it's going to be giving out information, and I mean, there are disclaimers all day for this, but at the end of the day, you don't want to be hurting people with the tool you release, right? So liability, yes, absolutely. The risk of causing harm, I think, should absolutely be a part of this consideration as well.
Should doctors be scared of this? Because you see these percentages in accuracy, it's comparable. And the only way is up. We know it's going to get better.
We know it's going to get better.
So this is just the start. And I understand, and we'll see that a little bit later. It's about asking the right questions or layering the right questions. And of course, these are prompts. But if you do that correctly, you can get very far in getting the right answers. But it's so much. It has such a broad view on everything.
There's a high bar for use with it if you want to use it accurately, and that bar is that you have to be an expert in the area to know that the results it's producing are not just garbage, that it's not telling you something completely out to left field that's based on, say, a common misperception in medicine. I think scared is a very emotional term for this.
You know what I mean.
I know what you mean. I think scared in what context, right? In terms of a diagnostic context, it's very exciting that you have a tool that can take in information sensibly in an unbiased way and spit out ideas of other things that this could be. These may be good, they may be not. It's just a completely different way of carrying out medicine compared to current practices. And I think maybe that's where the fear comes from. Not just the usual, is this going to take my job? Is this going to force me to retrain? But also fear for the patients. How reliable is this going to be for them? How accurate is it going to be for complex cases? What about the cases that I deal with particularly? Is there a way to make it better for those? And how well is it doing in the medical system in which I'm embedded? Because when you change medical systems, the performance of the bot might change too. And if the performance changes, then do we need to then retest it specifically on those systems? Or do we have other tools available in AI, for example, cost curves are one of those, that are used to dealing with ambiguous populations and a range of responses?
If you take it, if you go a little bit further in the food chain and you go to medical schools, and of course in America and Canada, these are more commercial. They're very expensive. In Holland or in the rest of Europe, it's more government sponsored. It's a different way. But if you would be a professor, you work as a researcher, but if you would be a professor teaching medical students, shouldn't we, knowing what's happening and knowing they can't read every medical research that's coming out, should the whole training of doctors and nurses maybe change? Because information is readily available. It's just it's like extreme triaging. It's you need to be able to ask the right questions continuously in the right order.
That's
in
right.
order to get the right answers.
That's right. And so, I mean, it becomes less, should we be using this, and how can we not be using this? Because we need to generate that expertise in order to have people who are experts in asking questions to chatbots. We need to have a whole domain of expertise developed around understanding the reliability of them, how they work. I think, coming back to your question about med schools, yes, we should absolutely be incorporating them into training. And actually, I think we have a moral imperative to do so, because when we take all of those opportunities for people to practice better medicine and we lock them away behind essentially having that information inaccessible, it does nobody any good. So if I have a tool that can sum up the results of a paper, talk about whether it's good or not in the context of other research, what the strengths and weaknesses are, and I can have that generate those summaries in a matter of seconds and synthesize those summaries in a matter of seconds. So we go beyond the traditional academic abstract. When we synthesize those information, those data, suddenly people are jumping ahead because they don't need to put in all the time for that initial reading, the initial synthesis. They don't have to essentially be a literature reviewer and then switch back to being a doctor.
And what will happen to all of course, in the teaching in the universities, but what will happen to all the protocolized medicine? Because we know, and that's partly from research, partly from what's happening in the world, partly, for instance, from Chinese medicine, that everything that's protocolized and compartmentalized, if I'm saying it correctly, is keeping us away from a holistic approach where we need to look at a person as a whole, and sometimes you have pain here, but it's being caused by another part of your body, and they don't look at it, and you just get medicine and x-rays and what have you to find something that for another doctor makes perfect sense, but for this doctor it doesn't make any sense.
So essentially we need some sort of error detection system that connects the information between the doctors and says, there's an interesting test result here and an interesting test result here, and I'm the tool that puts them together and alerts one of or both of the physicians to say, hey, I think you should look at the interplay of these.
Exactly, because if you go to, for instance, to a ear, nose, and throat doctor, he'll ask questions about the complaints in that area. But he won't ask questions. Exactly, he won't ask questions or about do you have stomach ache or other problems or I don't know, skin rashes, which might be connected to each other, but he won't ask. So if you don't get asked, you don't give that information because you don't know it's relevant as a patient if you're not educated in the medical field. But
and
if you have
an interesting kind of point, sorry, just that's an interesting kind of point, because really for one of the first times we've been able to directly harness other people's experiences in this large language model. And that's something that is letting us take these shortcuts. Now, how good those shortcuts are, we still have to determine. But as it stands, I think there's going to be a lot of room for growth in that direction towards quick and efficient use of information.
I totally agree. And if you look then one step further, we know for a fact that people and consumers or patients are more reluctant. Am I saying this correctly? They're easier to give answers. There's less shame if it's to a chatbot. There's no judgment. Let's say if it's some awkward problem. And we know it happens, and it's in financial situations and it's in medical situations. So
absolutely.
Shouldn't we, or shouldn't medical schools not propagate and promote and push online triage, but a holistic triage, not just, okay, you come in for ENT problems, but I'll ask you about the rest of your body. And then with AI having suggestions that you need to have a look or test blood or whatever, in order to see if there's some interconnection, and maybe he shouldn't be at the ENT, but I have an example. My father used to be, he passed away, but he was an ENT, ear, nose, and throat doctor. And he used to get patients from all over the Netherlands with very specific problems, ear problems, nobody could solve them. And he worked together with a manual therapist, a physical therapist. And the only thing when they came in, he just pinched their neck. And he said, well, first go to the manual therapist or the physical therapist, and then you come back here if you can't solve it. And usually, 9 out of 10, they went for 2 treatments and the problems were gone. They didn't come from the ear. They came from the neck or the vertebrae or whatever. So
interesting.
Very interesting. But if you look at the healthcare cost and the for these people who travel from one part of Holland to another part of Holland. Holland is not so big, so it's not that bad. But imagine doing that in Canada or the US.
And driving 3 or 4 hours to get to a hospital.
And the doctor saying, well, you know what? This can be easily solved. Go to this guy and he'll fix it for you. Or so that's a little bit more holistic approach. And it's not the obvious. And if these cases are described in scientific research or papers or whatever, or online, then it will be findable and usable or in ChatGPT or other toolings to get a better diagnosis or differential diagnosis, and start with the simple stuff first and not medicate. So eventually you might get, because of that, the healthcare costs down and the speed at which people recover and less invasive, because all this medication is also costing a lot of other problems.
Well, that's exactly it. And I mean, this comes back to how are we going to use our system's existing resources efficiently to get people the care they need without making them use their own resources at the same time. We're dealing with, especially in Canada, we're dealing with a geographical situation where if you're out in the rural area and it's going to take you half a day to get to a hospital, you have to seriously consider if you need to go there or not versus a 10 or 15 minute trip when you live in the city, right? So we have, I think, the potential here for tools like ChatGPT to create more equitable healthcare in a way that will let people without similar resources get access to the same knowledge and the same information. And that's very important, because when you have people getting different access to care, different knowledge, one of them sees an ENT, the other one sees an internist, you're going to get different sets of care. You're going to get different treatments. You're going to get, as you've brought up, missed information. So I guess another big part of this is how do we train ChatGPT to recognize when, and I say ChatGPT, but I really mean any LLM. How do we train them to recognize when we're missing information?
That's an interesting question. Let me answer that with a question in order to dive a little bit deeper. Knowing or understanding the speed at which these models are growing and will be growing, should we be training these models, or should we have a layer in between where we curate the output of a model and curate the input of the model? Because, as we know, the answer is as good as the question you ask. So,
that's exactly it. So the question is should it be in the model, or should it be on top of the model? I think my answer to that would be one than the other, because we've seen that people are more comfortable using models with some human elements, some human training. This is, I think, part of why ChatGPT exploded as it did, is because those responses were just that little degree closer to what we were expecting. And it was that little degree closer than what we expected that made it magic and gave that sensation that you, at least when you initially used it, that you were talking to something thinking, even if not a human.
It fooled us, huh?
It certainly did. And it's surprising to see the vehemence of people when they find errors in it, about how annoyed they get. It's strange because it's still just a tool. It's not an entity that is producing consciousness or producing some sort of contribution to our society right now of its own accord. It is still just that same principle of, yes, we've trained a model, now we've trained an especially large one, and then we've refined it based on human inputs. So then coming back to your initial question and my response of one then the other, I think we start off with these models using human inputs to allow people to get used to this very new way of communicating and very new modality of communicating. And then we start to look at how do we recreate that human expertise as its own secondary model that we then put on top.
See, this is interesting because everybody's calling it, or they call it generative AI. Mm-hmm. But I think that's incorrect because it's it's regenerative AI. It's regenerating what's already out there. Yes. So it's not generative. It's not generating anything new. It's combining maybe existing stuff, but that doesn't mean it's new.
And I would take it even one step further and say it's reluctant to generate new material. So one of the things I was interested in with ChatGPT as an intellectual experiment was which parts of Shakespeare did Shakespeare write and which parts were written by somebody else. And I figured if you have a language model that can assess connections between words very easily, that would be a good question to ask it. When I actually went and did that, it was really reticent. It kept coming back to, well, scholars believe both. You can't really tease apart this complex case based on people who aren't around. And really, when it was forced, it would give a couple of passages that may have been written by other authors. But as you say, there's nothing in there that's allowing it to produce its own thesis. There's nothing that's coming out that is such a new concept for us or a new way of looking at things that you couldn't trace that back to a combination of its training inputs.
But the good thing about it, because this is actually not such a good thing about ChatGPT, but the good thing is it is so much faster in looking at everything it's got in its database than any human could possibly do. So if you look at going back to the medical field, it's impossible with the amount of literature or articles or research that's being published in the world to take that in. It's impossible. They have no time to read all the magazines and all the articles. It's only what's being put forward to them by either medical companies or their peers, or specifically in a country. But you miss out. I'm pretty sure that Dutch researchers don't know half of what comes out in the States or in Canada. Because it's impossible.
Any of us know half of what comes out in any of our countries. There's so much information out there. It's like a fire hose. When you take a look at the first couple of months of ChatGPT coming out, it was released November 30th, I think, last year. By the time we hit it was mid-January, I did the search, we had over 1,300 articles on Google Scholar.
Okay.
How are you supposed to keep up with that kind of amount of information if you'd like to retain being up to date, current, well-read in the field? You have to pick and choose right now. And I agree. When we have
based on what?
That's
based
exactly
on what do you
it.
Pick and choose? It's impossible.
Based on your own expertise. Coming back to the problem, I'm looking here, but the problem is here. And now we're just in a different context.
Yeah, that's one of the things that, for instance, if you have there's people that have cardiac problems or think they have cardiac problem, but actually it's gastric acid, and they think they have a heart attack, something like that. But it's two different fields of expertise, And now this is one thing they know, but there's more of that kind of problems that sort of appear as one problem, but actually caused by something else. And I would love to see that we take that all the way back to the patient himself, and ask a full stack of information in order to connect the dots before the doctor looks at it. And then still the doctor needs to use his expertise and understand what's happening and judge if the information is correct and makes any sense.
I think there's a company out of Stanford that Suchi Saria is running. I want to say where they take a look at your EHR and then they
EHR, explain for the viewers.
Sorry, electronic health record. So
okay.
that's when you go into the hospital, these are your records.
So basically all the comments of the doctors, the blood works, the radiologist, everything.
Every time you go in, it's all of the information that's taken down and is available to the hospital. So this company takes the data from the EHR and then looks for changes in different metrics of health that would indicate problems are happening. So it's essentially having a secondary system looking at all of your records as they develop and making those little catches.
So so basically, let's say you do a blood test for certain things and it has a certain value, and this software would pick up that it gradually goes up a certain value.
That there would be a change indicating that a specialist should take a look at this data.
So would that then go towards preventive medicine? Because it's already happening. So I'm not sure, is that preventive medicine or...
I believe what they're doing it towards is making sure that people don't have health problems developing without knowing about it. So it's essentially an automated check when you go back to the hospital that says, okay, you have this new test information. Is there anything else in here that we need to connect to other health issues?
So ideally, if you ask me what would then need to happen, the system recognizes, okay, there's a change, and it automatically should generate a triage question or a set of triage questions, understanding the change and asking questions about that.
That's right. And how do we make a nice, efficient set of triage questions so it's not 50 questions that somebody is struggling and holding their head and trying to answer at the same time as they're feeling terrible? We need to make this a nice, compact diagnosis package.
So as a researcher, how do you see that happening? Because what I see, my context is I see a lot of startups, scale-ups in healthcare, but they're all like the doctors. They're compartmentalized. They're in a certain field. You have dermatology bots where they compare photos of your skin to a database, which is perfectly fine. But it could, it doesn't look at anything else. Then there's wearables connected to measure your heart and other stuff. So how do we go from all these separate? How do you view? I'm asking the wrong question. Sorry. How do you view all these separate columns developing? And does it ever go, or should it ever go to a holistic approach? And putting all that together. Maybe it's too big, too complicated. I don't know.
No, I think it's an interesting question, actually, because we experienced this a few years ago. We were working with some data from Pfizer. So we partnered up and we worked with some antidepressant data. So these are pills that you take when you have major depression or an associated problem. And the problem with antidepressants is that they're only about 50% effective when they're first prescribed.
Oh, wow.
And the thing that most influences prescribing accuracy in terms of effectiveness is physician experience. So an older, more experienced psychiatrist will probably give you a better diagnosis or a more effective treatment than a less experienced psychiatrist. And this is great for the one little problem that we are working, right, which is medication response. We can come up with a nice little machine learning system. It picks out 6 different factors that are easily askable to someone with depression and uses that to predict treatment response at 8 weeks. So what we came up with in there are 2 unique parts of this. The first part is having that data set and having that data available, right? And that's something that we see lots of efforts in science to try and make data sets more public, to try and make things more accessible to other researchers so that people can actually ask questions of their own and aren't delayed by these walls that are being put up around the information that we need. The second interesting part of this to come out was the algorithm itself. And this is where I see opportunity for development with AI. With all that data coming out and coming online and becoming available, that's fantastic. But how do we actually deal with this in a holistic way? And so we need to start looking at how do we put algorithms together in a similar way to, for example, when you're building software, you put different functions into a program that perform different tasks. What we need is a higher level version of this, where we have an AI that is able to take algorithms and put them into a series by itself.
So basically, then you would get differential diagnoses on the side.
Exactly. And how you deal with that, there are a number of different ways. You could have it so that the only diagnosis given are the ones that all of your algorithms line up on. You could have it given such that at least 2 of them have to make a certain diagnosis. There are a number of different ways of figuring out how you want the algorithms to work. But at the end of the day, the big piece here is connecting them all together and how we're going to do that with both the data and the algorithm.
And where is that? Is it happening? And if yes, where is it happening?
I think it's happening very slowly. Yeah, right now we have a lot of labs that have
says a frustrated James.
Could always happen faster, right? Right now we have a bunch of little labs out there, and they're producing small products that are compartmentalized. They have expert oversight, and they are trying to address specific problems in research or medicine or business. And where I see this going is as those companies grow and develop, they're going to start to look at other problems that their product almost solves and merge or collaborate with other companies or research labs, whatever environment you're in, and start to put those pieces together. So I think we're going to see those current little disparate labs that have specific algorithms and specific tools start to come together to solve larger issues and start to transform bigger issues as they build up that expertise and that stability and that knowledge of their own. Because as we're going through this, of course, we're all trying to learn these tools at the same time as we're applying them. And as we've already talked about, when you have this fire hose of information coming at you, it's difficult to balance that and do both.
I just thought of something. What if you would approach it the opposite way? Let's say you have one model and you put stuff in that model or information in that model of that patient, and you would use the information you put in and put that in another model and say, based on this information, it could also be X, Y, Z, and then start asking the relevant question, did you or do you experience X, Y, Z? Did that happen, or are you feeling this? That might be suggested, so you need to be very careful how you ask, but so it's not a suggestion. But you could verify the opposite way and start eliminating other diagnoses. And so if you put in, it's just sprung to mind. If you put in X, Y, Z, okay, you have 5 variables. And you say, okay, what we'll do is, like in chatbot software, they use different models, large language models, to produce an answer, and they calculate the score, so how accurate it is. And they use the one with the highest accuracy. What if you would do the same thing here, but different? You say, okay, I have an algorithm, and that algorithm tells me it's these 5 things tell me it's this diagnosis, but this algorithm only works in psychiatry. What if I would take that and put it in a different algorithm, which works in internal medicine, for instance, and let it generate questions instead of answers, and that those answers are new input to the model in order to understand what's going on.
So essentially taking just to see if I understand this right, then if I'm conceptualizing it in the same way as you want to train up one model, ask it some questions, ask a patient some questions, and have the model produce a little bit of information, and then take that information, put it into a second model, and have the second model ask the patient some more questions based on what it's interested in, or what its priorities are. I keep anthropomorphizing these.
No, but it doesn't matter. I understand. That's exactly what I mean. And what if we can't get one company to connect all the dots, but we can get another company or a university or whatever to make the master software, basically the master bot that sort of takes the information and puts it in all these models and see what comes up. And based on that, you ask questions and see what happens.
Oh, that's interesting. Kind of. So essentially, I would be asking that larger model to make a cardiac surgeon, or
for instance,
ask the questions that would be useful in cardiac diagnosis, for example.
So yeah, the problem will be, which questions would you ask this, based on this information, would you ask the patient in order to create 5 differential diagnoses? And then it starts generating questions. And the answers determine what happens next. So if it's no, okay, we know, we hop on to the next model. But if it's yes, we take a deeper dive and we start triaging further.
Well, and I think that's interesting because that goes beyond current offerings like Ada Health, as far as I know, where they're asking, using that same format, that same framework of asking questions to get to a diagnosis, but they don't have that second and third and fourth model taking different looks at it. So I think you're onto something there. That's an interesting idea.
It's the best of all worlds, not best of both worlds.
Exactly.
And that would propagate the holistic approach. Well, you're the researcher. Maybe you should research it, see if it can be done. No, but seriously, if you look at it from a patient's perspective, we all know if you take medicine, it creates side effects. None of these models, they ask you questions about your health, etc., but they're not connected to databases or information or the paper that goes into the medicine where I say, these side effects. So you need to do a cross-check. Okay, are these complaints in the triage caused by any medication you're taking? So you should also have a medication list, all the side effects, and the cross-section of these medications, creating something if they're taken together. That's also a thing. And there's I don't think the human mind is capable of doing that efficiently. So there's only AI and computing power will be able to do that.
Yeah,
so if
not with the huge amount of information. I mean, it's a problem and a solution of our own making. We've produced so much information, we're unable to use it, but the information is there and it's so very close. So when we get into LLMs and we finally find a way to access that, I think that's why there's so much excitement.
Yeah, because we all see the opportunities, but behavior and opinions traditional behavior and traditional opinions need to be changed a bit. And that starts on the one hand with research, education of doctors, but also another thing that that worries me is that doctors that are currently working, they need to be trained in using ChatGPT or other models to understand what patients will be doing and are doing, and be ready for them when they come into the practice and say, hey, I have 5 articles here. Did you read them? And then the doctor has to say no. And then it's like, what kind of doctor are you? You don't even know about my disease. And here's the article. It's new.
And then suddenly we're away from a productive clinical interaction and a strong therapeutic alliance, and we're into an adversarial connection here where the patient is going, well, I've done all this work and you've just dismissed it, so maybe I should dismiss what you have to say in turn. And by the same token, the physician is probably looking at this, if they're not familiar with ChatGPT or any of these, going, oh, it's an internet search.
Yeah, Dr. Google.
Why should I trust that? I have patients coming to me with those all the time.
Yeah, but there's another thing that will be happening, if you ask me, is that these patients come in, and of course in these differential diagnoses, there will be horrible stuff. We know that. There will be so people will come in thinking they're dying or have this horrible disease with horrible consequences, and they'll be demanding research or not research, how do you call that? Physical testing, blood testing or X-rays or whatever, or scans or biopsies to exclude that diagnosis. And if they don't do that, these people will be psychologically harmed because they're worrying the whole time about the diagnosis that they never got, but somehow ChatGPT made up or came up with based on their input.
Well, and that's very similar to a lot of the controversy that I've seen around discussions on this, which is errors of commission that these tools produce, right? So these are things where they've given you a differential diagnosis based on incorrect information, or they have hallucinated an output. It's wrong in some way, right?
You have a perfect example a little bit later.
Yes, we have a good example of that coming up. Sorry, I've lost my train of thought there.
You were saying that the errors they come up with.
Right, errors of commission and omission. Right, so we have two problems here. The errors of commission are the ones where we're getting spurious information. The errors of omission are the ones where we haven't taken an input that we should have taken, right? And this is the other side of that clinical interaction is we could be using these tools essentially as just a little, hey, you need to ask about this. Hey, you need to ask about that. You know, the patient has come in, they have a history of a certain disorder. So there are a certain set of questions that you should be asking that are related to their current problem, right? And so I think that's another opportunity that we're going to be able to address is working on making those clinical interactions more equally weighted between the information coming in and the information you get. And that is going to produce a much more actionable appointment for people when they go in, because they're going to understand coming into the appointment that the information has been taken in a structured and predictable way. And once that information has been taken in, it's been assessed for completeness. We've taken another look at that. And then on the outputs side of things, the doctor is able to provide those recommendations along with sources. And the patient is able to take that information away and not have a risk of coming away and saying, well, that doesn't sound right. How do I know that? Without being able to go and actually look it up. And that's something that we don't do right now because we just don't have that ability to go on the internet and find information unless you do this as a job. And even then people get tricked. But you go on the internet and you have to find the correct information. You need it in a format that you can use, and you need it in a way that you are sure that it's not giving you something that somebody just wrote for attention.
Yeah, that's. So, I understand what you mean. Yeah. Would you then be pro a situation where we would be, how should I say this? In a situation where we'd be continuously triaging the patients in order to monitor them. So instead of asking someone 50 questions, ask one question a day.
Oh, that's interesting.
Because I would love to see a situation where people, where we go into preventive medicine, because I don't have the literature to substantiate it. But if I hear doctors talk, they say, well, a lot of the problems, if people would have come in earlier, but they don't know, we would have been able to treat them. So what if you know which questions to ask and ask them continuously, but one question a day keeps the doctor away.
This is hugely applicable because in children's health, it would be great to start kids training early and being aware that, hey, your health changes as you grow and these things happen, and you should be being encouraged to pay attention to that in order to keep your health good as you age. I see that as a positive way of people being able to interact with these tools.
So basically, healthcare should be educated in the school system.
Yes. And why shouldn't it be? Once we have the ability to put together information in a reliable and consistent way that we can deliver it to kids in a format that they don't mind learning. For example, if we have an LLM write a health education plan in the context of a young adult novel, we could very easily introduce that as a curriculum in school.
That is a very interesting thought, actually.
So I'm not sure how the school system over there is set up, but I think that over here, at least, we have a set curriculum of books you get for certain courses during the year, right? And those books change,
the government tells you which subjects need to be addressed in the schooling and in a certain subject, and then there's a certain a couple of books that you can use, but they all cover the same stuff.
So then, I guess the extension of this is once we have the system in place, we can also update that rapidly to match new information coming in.
So basically in biology, you should have self-care or something like that, understanding your body, and you could make that age appropriate. That's actually very interesting and interactive.
Yeah.
That is actually, that if you think about it, if you want to lower, I think it's mind-blowing, because if you think about it and you start educating kids and you want to lower the cost or in future healthcare or not raise the cost, that starts indeed with kids being aware and educate them well. It's the same if you would educate kids in financial awareness, how to deal with money, there wouldn't be as many problems.
That's right.
They grew up with that.
Now, are you aware of any really high-quality tools for kids that would allow them to take in this information as it exists?
Well, I could say TikTok, but I don't think that's appropriate. They're all there, but no, I'm not aware of any. But then again, I don't have small kids anymore in school, and so I'm not sure I'm in this world. But I haven't heard of any application or, for example, that you could ask medical question as a kid in WhatsApp or in Signal or Telegram, where you get age-appropriate answers explaining what and how and when to go or not to go to a doctor or what to do.
And by extension for younger kids, simple questions like, am I hot? Okay, I need to tell mom.
Yeah.
Right. It's this very, because, with children's health, you have this continuum of them being able to communicate, right, as they age. So when they start off, young kids who get an ear infection won't say, my ear hurts, right? They don't have the vocabulary. They don't have the language for that. What they'll do is they'll pull on their ear.
I know, I've seen the kids in my father's practice.
There you go. So you've seen this before. And we can tease out all of these little, I guess, tells for when somebody is sick and enable them, give them that language, give them those skills early on to be able to communicate that. And I think that is going to have a huge impact on our ability not only to not only on our expectations around what we expect going into health, because if everybody's more knowledgeable, you will have a higher expectation of care. But it's also going to affect our society in terms of what is a generally accepted level of medical literacy, right? Because if you suddenly have all of the kids knowing this information and what to do in these situations on a regular basis, then you produce adults out of that eventually who are also going to have that reasoning in place. They're also going to have that vocabulary still in place. The training has already been done. And now we're in a process of updating information based on best available evidence rather than just trying to essentially do this in a quantized form every time a major update's released.
But aren't we also then training kids to be great prompt creators? Because basically we would be teaching them how to ask the right question.
Mm-hmm.
And that's to understand that you have to give an elaborate answer or a concise answer in order for the system to do something with it.
So I guess that brings up another question then. What do we do with the people who don't adopt or don't want to adopt? How do we maintain equitability of care?
Well, the good news is we're going to have doctors that won't adopt either. So
fair enough.
So there will be an equilibrium. But you have a fair point. It's the same problem. If you look at customer service, and of course, the chatbot world, and we love to automate everything. But then I have a mother of almost 82, and she's complaining, and all her friends are complaining that everything is on the phone and digital, and what if it doesn't work? What if I don't want to use it? And
that's a valid complaint.
It's a really valid complaint because I help her with a lot of things, and I see all these websites and everything gets more complicated. And I'm thinking, okay, if younger people, and I'm not that young, but wouldn't be helping older people, then it would be a total disaster. And of course, in 20 years' time, I'm in that situation where I need my kids to help me with stuff I won't understand or I'm scared to use or whatever.
And that's kind of the inspiration for our next project here, is this idea of intergenerational health education. So instead of just having the kids taught, how do we rewrite these materials in a way that people of all ages are going to appreciate and be able to take in a way that's useful to them? So you wouldn't write a young adult novel, presumably, and present it to your grandparents expecting that they're going to get a lot out of it. They might, but it would certainly be easier to be able to rewrite that content in different contexts and enable people to find a way forward with this that works for them.
I've thought about that, actually, and I'll be recording a podcast with someone who's busy in that field.
Excellent.
I think what we see is, if you look at the older people, they want to talk to someone.
Yes.
Okay? And there's a lot of, synthesia, but there's a lot of experimenting with, they call it digital humans. Of course, that's not correct. And right? You just keep repeating that. But if you think about it, what if you could make a digital human or an avatar or whatever you want to call it, or a lookalike of the doctor, of your doctor, who instead of letting you type the questions or the triage questions, it's actually talking to you, and you have it on your screen like we're talking right now. It's asking you a question, and based on your input, it asks you a follow-up question. Exactly the same thing as you would be typing, but now it's humanoid or it's human-like. And
that's very, very similar to what we're seeing in these miniature clinics in China that essentially look like vending machines, where it's not using a bot yet. It's still using telemedicine. So you get on a small screen at this vending machine with a doctor, and then he gives you a diagnosis, and the machine dispenses the pills.
Yeah, so they have a rudiment. Oh, sorry. There was a delay, so I thought, no, go on. There was a delay, so I didn't realize you were talking.
Oh, okay. So I think that's one step away from integrating some sort of human-like bot. But maybe there's a second step first where we have to get people used to the idea of telemedicine and comfortable with the idea of telemedicine as part of their healthcare routine, not we're in a pandemic and we've had to make these massive changes to how we do medicine and how we engage with patients. Maybe we just need a little bit of time to get used to that.
It's funny that you say that, because a couple of years ago I was in Morocco. I was in the Atlas Mountains, and they explained to me, I was with one of my kids, and we asked, so how do this is remote, how do they do healthcare here? Where's the doctor? He says, well, we don't have doctors here. It's quite a long way. But they have in every village like a small clinic with a nurse and a sort of a small pharmacy. And they have telemedicine. They have the doctor behind the screen, and he talks to the patient, and the nurse helps with sometimes asking a question or giving the injection. And if the doctor says, he or she needs to have antibiotics or an injection, the nurse takes care of it. So they have many nurses, not enough doctors. So they centralize the doctors giving remote access. And if it's really serious, they say, okay, we need to dispatch an ambulance or a helicopter to pick you up. You need to go to the hospital. But they triage and help people that way. And actually, it's not that weird, because if you look at COVID, what happened? You know how many GPs saw their patients through telemedicine?
Yes.
Lots. And all of a sudden it worked.
I'm definitely one of those patients.
Well, here's another one. But the point, we were so keen on, okay, we need to see the patient the traditional way, but you're not doing anything different than you when you see the patient remotely. He would still have to go to the pharmacy to pick up the medicine, which goes digitally anyway. So if you think about that, only in certain instances you need to listen to the lungs, the heart, or whatever. And they found out they can still look the patient in the eyes and check for whatever they want to check for. And one pediatrician told me, she said, finally I got a look into the house of people, and she specialized in allergies. And she says, and then all of a sudden you see, they never told me they had a cat, and also you see a cat walk in the camera, and you realize, oh, it might be an allergy to the cat, where you asked, they forgot to tell you, or you asked them and they didn't tell you. Or they had
and you wouldn't think of that without seeing it.
Exactly. Or they have people who don't speak proper Dutch, or the kids speak Dutch, or so other interesting things happen, and other information, soft information, comes up and becomes relevant.
How are older patients with that? Do they accept that system when they're rural like that?
Well, in COVID time, they didn't have a choice. And what happened was in Holland, which I found really weird, before COVID, the doctors and the hospitals would not get a financial compensation for a consultation, video consultation. So that was, so the insurance wouldn't cover it. So you could do it, but you wouldn't get paid. Or you would have to pay it as a patient yourself, which most people, we're Dutch, so we don't want to do that. So,
well, and I guess that gets into another issue here of how do we convince insurance companies to take this on? And
that's
also, I suppose, should a company that uses ChatGPT be paid for its use as a physician, or is there another... Or is there another way of setting it up if it's doing the same job?
Here's the other thing. You could turn it around. Why would an insurance company pay doctors if they can have ChatGPT or a similar system or curated system hand over diagnose?
Yeah.
And have like a centralized doctor's post somewhere which is on their payroll, so no profit margin. And they write out the prescription. This is mind blowing. This could hurt the system as well. Power to the insurance companies, huh? They already have so much power.
Well, and this is the issue: is how do we maintain the patient's rights and the patient's autonomy and ensure that our primary concern here is getting people better, not a bottom line. And bottom lines are important, absolutely. But at the same time, that doesn't do much good if you don't have patients.
You know what I think? That if, of course, this is a research thing, if we can prove that by using AI or integrating AI in a proper way, we can actually increase health or go towards preventive medicine, and in the end, in the future, lower the cost of medicine or healthcare in general. If you lower the amount of people that have to stay over in the hospital with 5%, these are huge gains. Huge. If you look at that worldwide, it's beyond everything we can imagine. It's billions.
Well, I mean, it's similar to the revolution that happened when Brent James introduced procedural checklists at Intermountain Healthcare. I mean, there was a huge impact on unnecessary procedures just from adopting this practice. So really, we have an opportunity here, I think, to use these models in the same way, except instead of a procedural checklist, now, as you've been suggesting, we have a holistic checklist, something that's developed over time, something that's maintained and that you take with you, and that can be used for longer term care. Because that's really the other part of what we don't have right now, is really good access to somebody's complete history of care in a way that we can take in an emergency situation and apply. So, for example, in emergency rooms, you might have two physicians working on a patient, one of them taking notes, doing any procedures that need doing immediately, and the other one will be looking up information at the same time. To try and figure out medical history, yes, to go over their medical history, to try and figure out where these problems came from, to try and figure out if there's something associated. Now, these tools are already in development. We already have tools that are trying to pull information out of EHRs, electronic health records again. But what we don't have yet is that complete holistic tool that can take something quickly, efficiently, and then apply it to the current context, or even, actually, this would be even better, something that takes the patient's current symptoms and searches through their medical history for indicators that there's an emergency level problem there.
Yeah. And what if you have WhatsApp asking you a couple times a week a question on certain things in your health based on your medical record? A chatbot, basically, and adding that to your record. Then if you look back, you can recreate what happened, and you probably can, first you can recreate what happened, and then later on for other people, you can predict what's going to happen. Mm-hmm. It's actually, you go to predictive medicine, and please go to the hospital now because you've been answering these questions, and you need to have your heart checked or whatever. Or, and if we could go in that direction, I think a lot of problems could be, in early stage, could be solved.
So this gets into an issue of medication adherence, taken to a different field. So instead of medication adherence, this is advice adherence. So are you actually going to get checked out? And what are the characteristics of a chatbot that make people more willing to engage in the recommendations that it makes? Do we need, for example, a secondary system that books the appointment for them? What are the barriers to this next level of care?
I would assume that, because you wrote me something in the app about empathy, about this medical company or this company in Belgium.
Yes, that's right.
That tagline, bringing empathy back in healthcare, which I find a bit weird because there is already a lot of empathy. I mean, most doctors they live on empathy. That's the way why they can still do this. Otherwise, Absolutely. They would have quit. So I wouldn't say there's no empathy. There's just no time or a lack of funds, but certainly not a lack of empathy.
Oh, absolutely. It's not that there's a lack of empathy. It's that there's no time to show it.
Exactly. So but if you would go to the patient side and you say, okay, how can we get them in? That if something is wrong with you or potentially wrong with you and it needs to be checked, you do want to talk to a doctor. So it's fine that the bot tells you, okay, Ed, there might be something wrong with you. You need to check in with the doctor. I would assume that if then the assistant of the doctor would call me, it's like, hi, our system told us that it decided that you need to see the doctor. We find that very important, and you can come in tomorrow. But first you need to take this blood test, blah, blah, blah. So we can immediately see what's wrong or if there is something wrong. And I think if your doctor calls you and tells you to come, you will come. That threshold of not going.
I agree, actually. I think that people would be more likely if the doctor calls them up and says, hey, I got to see you. There's a specific reason for it. Yeah, you're right. The issue comes when people don't. So we have a major issue in Canada right now with not having family doctors and not being able to find family doctors.
You mean GPs? General practitioners?
Having somebody who knows you, who's taken you on as a long-term patient, who knows your medical history. It is so difficult to find a family doctor right now. At least in Alberta, I've been searching for over a year now. And there simply isn't the volume of availability that we need. And so when you're taking up a lot of doctors' time doing administrative work, doing everything that is not the core of their practice, everything, really, if you want an easy metric for it, it's everything that doesn't involve empathy, right? All of those things can be taken and done by other systems effectively, reliably. We need to put it together still, but the technology is pretty well there.
I agree.
To take on things like intake questions.
And it can process it and do stuff with it. And then we could go to the situation where it's a bit like China, where, from what I understand, in China you don't pay the doctor to cure you; you pay the doctor to keep you healthy. It's different. So if we look at what we just thought up, basically, the doctor is trying to keep you healthy. He's
totally different mindset.
So it's a proactive approach instead of a reactive approach. And I think eventually that will drastically lower the cost of healthcare and puts the fun back into the work for the doctors. Because
exactly
they don't want to see their patients die. They don't want to see their patients suffer. The earlier they catch something, the better it is. So they studied medicine to help, not to have people die or be very sick and in pain and everything.
Which is fantastic. How would you deal with that in a private healthcare system where you have fee for service?
I think if you that people would actually, the people that can afford it would pay a ton of money for it to not get sick and live longer. I mean, isn't that the holy grail? People are looking for it.
Well, I'm sure people do pay that.
Yeah, and I don't know how it is in Canada or in the States, but in Holland we have imaging clinics, where you can do a full body image, MRI or CT scan, I don't know, or both. And basically you pay a shitload of money. Well, actually, compared to health, it's not that expensive. And they basically check all the vitals and make a scan of your lungs, your liver, your kidneys, and do full blood work. And it's actually preventive medicine. And I think if we would introduce that, but a lot of it can be done digitally, for everybody.
Well,
it's in Holland also they're doing a research. They're looking for intestinal cancer, if I'm not mistaken. And basically people can up from a certain age they can send in their stool, and it's being tested for stuff that needs to be in there in order for a chance to be cancer. And this way they try to catch cancer in an early stage. But it's yeah. So it's actually good that they're doing it. But you could do this for a lot of diseases, and just by asking information, and that information, if enough people do it, you get enough data to go to predictive medicine, and you know who to ask what when. In order to
and we know that people are already willing to contribute to that kind of data set as soon as you tell them, hey, it's for other people's benefit. So we actually have a nice easy in here, which is we just have to remind people that, hey, when we're using your data, this is for the benefit of other people. And I think that's also a very nice way of looking at this, is that all of the data that we're collecting and all of the data that we're using now is eventually going to help other people's health. It could help your kids' health. If you have a long-term history and you have a couple of generations of health records, then you're going to suddenly be able to get all of these intergenerational problems out of it.
Wow.
Right? And be able to connect those between patient histories.
I would imagine that you would have DNA analysis in there as well, and comparing DNA and finding defects which you otherwise wouldn't find.
I'm trying to come up with some sort of pun for 23andMe in a clinic, but
coming up with a pun. You did some testing in ChatGPT, and
yes.
I think it would be really nice to share it. What you, because we discussed before to see what we can do with ChatGPT and what it comes
Absolutely.
up with. So if you would like to share that.
Yeah, so I'll share my screen here.
I think you're gonna. We summed up enough ideas to have 10 people do a PhD.
So what we have on the screen here for everybody who isn't on video is we have the ChatGPT window up, and I've started off with a prompt to it. What we'll be looking at today is a virtual care team. So I've given it the prompt, give me a complex pediatric case that will require at least 5 members of a care team to manage effectively. And so what it gave me here is a child with severe congenital heart disease. And it goes through the different members of the care team that it thinks would be appropriate. So we have a pediatric cardiologist, a pediatric cardiothoracic surgeon, pediatric intensive care specialist, a pediatric nurse, and a pediatric PT. So I realized when I was writing this, okay, I've asked it for the care team, but I don't really know a lot about the patient. So we go, and the next prompt is, give me a detailed medical case report of this patient. So ChatGPT can go through, it can give me patient information, presenting complaint. It divides all of this information up into different headers. Clinical findings, diagnostic assessment, management, outcome, and then it discusses the case a little bit.
It's written. If you read it, it's too much to read out loud. But it's like
too much to read out.
Yeah, but it's like it's a scientific approach, basically, like the way doctors would approach a patient.
Exactly. Maybe I can just read one little paragraph here. We'll do presenting complaint. We'll say the patient was brought to the emergency department by his parents with a complaint of worsening respiratory distress and poor feeding for the past 3 days. On examination, the child was noted to be tachypnic with a respiratory rate of 40 breaths per minute. His oxygen saturation was 85% on room air, and he had intercostal and subcostal retractions. He appeared pale and lethargic and was not interested in feeding.
Well, with that respiratory rate and that saturation, it makes perfect sense.
So, not a perfectly detailed case by any means, but you certainly get the idea of what it's going for with the case it's created. So once we had that, we now know that we have a pediatric case. We now know that we need a care team, or we think at least that we need a care team of about 5 people to manage this. And so the next question I asked was write a care plan, including contributions from each of the 5 care team members. So we go through this and we see various things that each member of the care team is going to be doing in the context of their job. So, for example, a pediatric cardiologist, here it says, determine when interventions such as cardiac catheterization or surgery are needed to correct any heart defects and improve the child's quality of life. And I realized with that, I wasn't asking for the right kind of care plan. And this is where we get into prompt engineering and semantics a little bit. What I was trying to do is get it to write a home care plan for once the operation is complete, how does each member of the care team contribute to that child's health? What should they be looking for? What should these steps be at home in order to generate this sort of holistic view of how we should manage this case? So I also asked it to write this at a grade 8 reading level for parents who are not especially health literate, using plain language terms, and give it to me from each care team member's perspective. So we get quite a simple plan here. And this is where we started getting into realizing that ChatGPT isn't just going to make a whole care plan on its own for you. You're going to have to tease this out a little bit. So it says, well, we'll come back to the cardiologist because that's the example we keep working with here. They say your child's heart needs special attention because they were born with a heart problem. We will check your child's heart regularly with pictures to make sure it's working well. We'll give your child medicine to make their heart work better and to remove extra water from their body. If needed, we may recommend surgery to fix the problem. Right? So very high level information. That's not going to be detailed enough for a home care plan. So instead, what we did is we said, write it from one of the care team members' perspectives. And I also said, write it empathetically, so it'll resonate a bit better with the parents reading it. One of the things that ChatGPT can do is it can write in different emotional tones. So it understands when you say empathy or write in a positive tone of voice, what to do with that.
And you specifically stated the role as an empathetic pediatric cardiologist.
As an empathetic, exactly. So now it's generated a letter for me to the parents from one of the care team members. So I'm not going to read out the whole letter, but it does go through the different sections. It does use a lot of first-person inclusive language, our care team, we, our goal. It talks about the care team's goals for the child and working on good outcomes.
And all the roles in the team. From every perspective, it gives information.
Exactly. So you can get all of that information, and then you can also synthesize it. So you can say, okay, I want to synthesize all that information from above. So now we have a bullet point form from each care team member, and you have specific recommendations from each. So for example, the cardiothoracic surgeon says, we recommend you monitor your child's incision site for any signs of infection, such as redness, swelling, or discharge. If you notice any signs of infection, contact the pediatrician immediately.
Makes perfect sense.
Right? Now, this is where we might have to get into prompt engineering a little bit more if we wanted to actually use this in a home care context. Because how often do you check for signs of infection? How bad does redness need to be? Is there an example here that you can maybe show the parents?
I was going to say pictures of examples what is not good.
That's exactly it. Here's a picture, or here's a short video. Here's something you need to watch for. And so we go through each of these. We see different recommendations being produced for each. But again, if you wanted this to be a complete care plan, ChatGPT doesn't have the wordiness. It doesn't have the lengthiness. It needs to write out a complete home care plan for a complex
not specific
case.
Enough.
So you need to do it piecewise. And we can get things out of here. We can get out specific home care instructions. It will switch up which topics it talks about. seems a little bit spurious as to which it's talking about. I'm not too sure exactly why. For example, it decided to focus on emotional support for the pediatric intensive care specialist and not, for example, for the cardiologist. So there is, I think, a little bit of work to do there. But then we can also synthesize those care plans into a care plan by type instead of a care plan by role.
And that's when you went deeper into the details.
Yeah, so this is where we got into different, okay, here are all of the different areas we've talked about from the different members of the care team. And here's how to put that into one plan with different items. So for example, emotional support is encouraging your child to talk to you or a member of the care team if they have concerns, giving them comfort, giving them some activities, right? Things that you would want to do so that the child isn't scratching at the incision site or feeling frustrated with the injury or anything like that. So then just finishing going through here. Right. So I also wanted to get a little bit more into specific details of the care plan around.
You gave him a name, by the way, in between. All of a sudden, his name is Daniel.
There we go. Well, now we know something new about the patient. I think I'd said it. Yeah, I'd said up here, write a detailed backstory for the child and their family.
It's our first child, and then the next one you say Daniel, and then he picks it up and he calls him Daniel.
Yes, so it remembers Daniel's name. And so the care plan for Daniel, I asked it to focus on medical history, developmental needs, home environment, and family-specific concerns and challenges to see if we could start taking these sort of general care plans and tailoring them to fit an individual patient, right? So now it's personalized to his name. Now, if we go back to emotional support, it's essentially the same information. So it hasn't taken anything in from the backstory we have up here that would suggest that additional emotional support would be required, right? And so, I mean, we can trick this back. We can audit this information. We can get the provenance of what parts of it came from the general care plan and what parts of it are specific to Daniel. And then I just did variations on that, trying to get more and more specific about different pieces of home care. For example, give me more detailed instructions for the incision site.
Yeah, you can go very deep into this, literally. But
very deep.
And then came the interesting part. We asked for where did this all come from?
And it said, I'm sorry, but as an AI language model, I did not use any specific scientific sources to write the answers to your questions. However, my responses are based on my pre-existing knowledge and training in the medical field, as well as my ability to generate human-like language. It's important to note that any medical information provided is intended for educational purposes only and should not be taken as medical advice. For specific medical questions or concerns, please consult a qualified healthcare professional.
This is interesting because it says it's trained in its pre-existing knowledge, but it can't tell you where it comes from.
So now you sent me something interesting before this podcast, which is something called a jailbreak for ChatGPT.
Yeah. And I used it yesterday and the day before yesterday to, in medical things, get me specific sources, and it did. And you tried, and it didn't. It refused.
And it didn't. So either something is different about the way it's responding to us, or there's something that's changed on the back end.
I wouldn't be surprised because they also did something on the Dan do anything now. They changed that too. So I think everything they're running after people that find loopholes and closing them, which is good. And at the same time, it's not because I think
this early in the process, it's smart. is what it is, because you don't want things happening to produce yet another AI winter where we have public confidence lost because you can't deliver on the results that you promised, or the results you're delivering don't match the expectations. So I think initially in the process, and also for people's comfort really with it, it is nice to know that there are some restrictions that have been put on this to ostensibly to prevent harm to the users.
I can imagine that, but on the flip side, if you're a patient and you just tried to get information, and
it'd be pretty frustrating.
And it tells you, oh, but I'm not giving you my source, and you know there is a source or there are sources, that is pretty frustrating, because you if you want to go to the doctor and say, I have this information, and maybe make him or her smarter, and then you can't, because you just can give the conclusion and not the source. Although there are other LLM models that do give you the source without discussion, so that's a good thing. It's happening, and I would assume, but that's just my thought, that models that really open up and actually give the source where they get the information will be the winning models, because I think transparency in AI and algorithms and everything is key to democratizing this knowledge and this information and the use of AI, and not being scared of it. It's something we can't stop. It's there. It's only going to grow and get better. And if we look at the percentage we used earlier, where we said, I think 87% accurate, ChatGPT, and compared to the doctor who was 84% accurate, and we're only at the beginning.
Very close.
That is, I'm not saying that doctors should be worried. They should embrace it and use it, become better doctors, getting faster to the right diagnosis, creating time to live their lives on one hand, and to be with their families, and maybe see more patients and make more people healthy, or getting them the right diagnosis. It's something in that field, and solve our capacity problems. Not by working harder, but by working smarter.
That's exactly it. We have a limited amount of resources to use. We've got to be smart about how we use them, and we have to be looking to use them in a way so that everybody is able to get healthcare. Not just a few people, not just a few people with access, but actual equitable treatment, equitable diagnosis, and equitable access to follow-up information too.
That's actually beautiful, James, because basically you're saying AI will democratize healthcare.
That's exactly it. AI will democratize healthcare. It's coming. It is happening very quickly, but there is an awful lot to do. And so I'm hoping that as we do more research and we actually go and test these programs out and generate this information, we'll see that expertise and that continued interest developing, and we'll see the stirrings of this more than at 3 months old, where it's already exploded so quickly. It's at this point, it's very exciting to see where it's going, but I don't think anybody really is sure of what the final form of that will take. I think as long as we can continue working towards a goal like democratized healthcare, then we will end up on the right path towards that.
That is beautiful. And if we can conclude with, if you could give an advice or a tip to, on the one hand, the healthcare system or the healthcare providers, and on the other hand, the educational system where we train doctors, and maybe on the other hand, the insurance companies. If you would split it in three, what advice would you give all three of them?
I think the advice going forwards for all three groups is approach this as a new tool. Don't put extra expectations on it. Don't go beyond its capabilities. But within those capabilities, there is so much interest, so many interesting questions. There's so much interesting knowledge to figure out about how these work and how these tools can help us in our lives and in staying healthy. Then maybe at the end of the day, the answer is just to use these tools with some cautious optimism. Talk to an expert where you're not sure of the information. But at the same time, don't be afraid of saying, this is nothing new. Sorry, I'm not phrasing this right. Don't be afraid of just using the tools and talking about what you found out, because that is what's going to inspire other people to actually get into this area and actually keep using these tools, both as patients, as physicians, and in this case, as insurance providers.
So again, here you're saying democratize the information on the experiences. Share, so that everybody can learn and improve. That's basically right. And if we do that internationally, we'll probably go at light speed.
Well, that's exactly it. The technology we have is now running at light speed. And so it's time that we figure out how to grow at a comparable rate.
That is a great quote to end the podcast with. James, thank you very, very, very much for this large chunk of time you took to talk to me and to share your knowledge with the viewers and the listeners. I'm just extremely curious what will happen next, and I'm pretty sure that we'll be astonished I can't even grasp what's possible. And I'm pretty sure we'll be looking at it. If you have interesting developments that astonish you, please come back on the show and we'll discuss them and we'll share them with the world.
Absolutely. Thanks for having me on today. It's been a real pleasure chatting with you.
Same here. And if someone is looking for you or wants to talk to you, how do they find you?
So I can be found online on the University of Alberta website or on Twitter and LinkedIn.
Okay, cool. Under your name, James Benoit. I'll put your LinkedIn handle I'll tag you in everywhere so people can find you. Thank you very much, James, and looking forward to chatting to you again in the future.
Looking forward to it.
Okay, thanks.